be having a lymphocytosis. So if there is a lymphocytosis, we generally consider it as a viral infection. But in certain bacterial infection like mumps, syphilis, and tuberculosis and brucellosis, that means in long-lasting or a chronic bacterial infection like syphilis, tuberculosis, and brucellosis, also lymphocyte count will be increased. Suppose if the patient is having a tuberculosis, rather than neutrophil, the patient will be having a lymphocytis because that's a chronic bacterial infection which leads to increased lymphocytic count. And in other conditions, thyroid conditions like thyrotoxicosis, ulcerative colitis, and immune disease, also patient will be having a lymphocytis. To put short, neutrophil will be seen in case of bacterial infection, and lymphocytosis will be seen in viral infection. But in certain bacterial conditions also there can be lymphocytosis, because I have seen in many patients with the port spine, they usually have a lymphocytosis. The reason is chronic infection, there will be lymphocyte count will be increased. Next. So in eosinophilia, as you know, eosinophil, it helps in ending the allergic reaction, and usually 2 to 4 is the eosinophil count. Eosinophilia will be increased in all allergic conditions. Either it could be a respiratory, it could be a intestine-related allergic, it could be a skin-related. In such conditions, there will be eosinophil count will be increased. Usually with allergic disorders like asthma, seasonal rhinitis, or any food allergy, there will be eosinophil count will be increased. Second, in parasitic infections like either hookworm, roundworm, amoebae, parasitic infections, especially in children, or whenever there is eosinophilia suspect, you should attempt for a deworming, because eosinophil count could be because of worms in the child. So in children, if there is eosinophilia, don't consider only respiratory allergy, but always consider about a deworming, where just a vidation or something has to be attempted, because that can relieve the eosinophilia. Next is in skin disorders, either it could be eczema, in psoriasis, any allergic dermatitis, herpes, and pemphigus. Any skin diseases, there could be eosinophil count will be increased. Next is a neoplastic disease. This is also very important in non-Hodgkin's lymphoma and chronic myeloid leukemia. I'll tell you one of the clinical experience I got. A patient, a female came. She said that whole of her body is having severe burning sensation. So when I checked the blood's differential count, her eosinophil count was so high, and she said there was a pain, slight pain in the axilla. So I palpated the axilla. There was a lymph node was found. I sent for an ultrasonography, and ultrasonography identified it as a case of multiple lymph node enlargement, and then diagnosed it as a case of non-Hodgkin's lymphoma. So in non-Hodgkin's lymphoma also there can be a eosinophilia. Then in other miscellaneous conditions like collagen vascular disease, ulcerative colitis, pernicious anemia, etc. In these conditions also the patient can have a eosinophilia. Next. Basophils, again, it's similar to the function of a mast cells. Next. And it is more seen in allergic reaction, chronic myeloid leukemia, polycythemia, etc. Next. This is monocytes. Monocytes usually gets increased by the end of the ending the reaction. Finally, after when the patient is about to recover from the infection, they will be having a monocytosis. Next. So, what is the importance of WBC in our Ayurvedic clinical practice? So, always that if there is an increased count of WBC, then we should consider it as a red flag. Normally in the clinic, if the patient is having a WBC above 15,000, I usually refer the patient for an antibiotic therapy, because above 15,000 it will be difficult for us to manage. If you are confident enough, my teacher usually manages up to 17,000, but I am not that confident enough to keep the patient up to that stage. I usually refer the patient if the patient is having a raised WBC above 15,000, I usually refer for an antibiotic therapy or find out what is the exact cause for the infection, and proper antibiotic has to be supplied. So usually I refer a patient. So in the IP and only don't keep a patient if the patient is having a WBC count above 15,000. A marginal increase like 12,000 or 13,000 or 13,500 does not cause any. Usually that is associated with other inflammatory. Most of the inflammatory arthritis like rheumatic fever, and then rheumatoid arthritis, etc. Patient will be having a slightly marginally raised WBC, which does not have much of the significance. But a periodically increasing WBC, which crosses the benchmark of 15,000, you should definitely refer the patient for the antibiotic therapy. Then, in the clinical practice, again, what is the utility? Suppose if a patient comes with the abdominal pain, you suspect it as a case of a appendicitis. So, whether the patient should be referred for an appendicitis or the patient is having a subclinical appendicitis, you have to check the total WBC count. If the WBC count is less than 30,000, you can definitely manage the patient with the, or if the WBC stands within the normal range, you can definitely consider it as a case of a subclinical appendicitis, and you can manage with the our Rasvanadi Kashaya, Gandha Rasayana tablet, etc. No need to refer a patient. And along with that, you need to go for the C-reactive protein. The C-reactive protein is within marginally raised with the normal or marginally raised WBC count. You can keep the patient and manage the patient. Or to monitor whether it is progressing or not, you have to have this WBC count. So WBC count is always important in the clinical practice. So the DC, when which condition neutrophil is increased, in which condition lymphocyte is increased, which condition eosinophil is increased, it is very important in the clinical practice. Next is the platelets. So the normal value of platelets is 1.5 lakh to 3.5 lakh per cubic millimeter. So normally in the clinical practice nowadays we face a lot of problem with the platelets because of a lot of viral infections are there. Even a simple viral fever, if dengue fever, any viral infection usually causes a reduced platelets. It is mainly because whenever usually in viral infection, they causes a infection of the bone marrow megakaryocytes, and it leads to a reduced production of the platelets. So nowadays, whenever the patient is having a dengue fever, we also usually immediately refer the patient. There's no need to refer a patient if you properly monitor, because in dengue fever there's no much medicine. Usually, patient have a reduced platelets when we give more of the IV fluids. That's the second study has come out that way. If you can manage the patient in your clinic, or if you have the facility to observe the platelet count, if the platelet level, if it goes beyond or less than 30,000, then only there is a need to worry. Up to normally in the clinical practice, at least in your clinical practice, you can keep a patient up to 40,000. The platelet count is up to 40,000. You can keep the patient and manage with our medications. Our medications is better in managing dengue fever because the complication, residual complication will be less, provided you should have a proper check on the platelet level. You should have a proper laboratory nearby, and if you can manage, if you can monitor the patient, if the patient is willing to be checked properly, then better you can manage dengue fever. So these platelets can be decreased because of many reasons. One is about the dengue fever. If there is a vitamin B12 or folic acid, as I said, all the blood elements require B12 or folic acid for the production. Or if the patient is having a liver disease, in liver, the thrombopoietin from the liver is required for the production of the platelet. So in such condition, the patient can have a reduced platelets. But one of the main thing which comes in our clinic is the idiopathic thrombocytopenic purpura. The reason is not shown, but the patient will be having a reduced platelet count. In idiopathic thrombocytopenic purpura, normally modern doctors give steroids, but our medicine with the Kumaryasava and Arogyavardhani continues for Drashadi Kashayam also continuously for 6 months would be a better medicine to manage this idiopathic thrombocytopenic purpura. But other conditions like hemolytic uremic syndrome, etc., need to be managed by modern because the renal problems has to be taken care, which is not with. But in idiopathic thrombocytopenic purpura and in dengue fever, if you manage the patient properly with our medication, with adequate fluid supplementation and proper food and our medicines, we can manage this reduced platelet count. Next. This is inflammatory markers. So whenever a patient whenever a patient develops an inflammation in the body, there will be always inflammatory markers will be elevated. So inflammatory markers are ESR, erythrocyte sedimentation rate, C-reactive protein, and plasma viscosity. These are the inflammatory markers. Inflammatory markers does not point out to a particular disease, but it is called as a sickness index. It means it gives an idea that something wrong is going in the body. It does not point out towards a particular diagnosis or a particular disease, but it gives an estimation or gives a message to us that something wrong is going in their body. It could be infection, it could be inflammation, it could be a tumor, anything. But whenever there's an inflammation or infection develops in a body, the inflammatory markers will be raised. The inflammatory markers are C-reactive protein, ESR, and plasma viscosity. Among that, ESR is one of the oldest inflammatory markers, but still in use, and it has got value. The newer inflammatory marker, that's a C-reactive protein, which is slightly costly, but it is more relevant in the present clinical practice. So now let's first come to the ESR. ESR is nothing but it's an erythrocyte sedimentation rate. The normal in males it is 0 to 15 and females it is 0 to 20. One of the problem with the ESR is that it has got variation due to many physiological factors. Suppose if you are obese, your ESR may be high. If you are menstruating, your ESR may be high. If you are pregnant, your ESR may be high. So many physiological factors affects the ESR. But as far as C-reactive protein is concerned, it does not affect with the too much of physiological factors. Now let me come to the ESR. So suppose if a patient has got a very high ESR like 80 or 100, it definitely indicates that something very serious underlying pathology is happening in our body. We need to investigate further. So investigation, how to investigate a patient with the ESR? Before going for that, whether a ESR is having any diagnostic value. So in 3 diseases, ESR is proven to be diagnostic. As you know, in rheumatoid arthritis, American Rheumatoid Association has considered ESR as one of the diagnostic criteria for rheumatoid arthritis. Second is in temporal arteriitis and polymyalgia rheumatica. In these 3 conditions, we generally consider ESR as one of the diagnostic tool to diagnose either a temporal arteriitis and polymyalgia rheumatica. In both these conditions, the ESR generally goes above 80 or sometimes it can cross 100 also. Also, if suppose if a patient comes to you with a back pain and if the ESR is above 100, then it indicates that there is a spine infection. Either there could be a port spine. A tuberculosis spine is the most common cause for the increased ESR. So likewise, it gives an estimation on a pathology. So always any investigation further has to be clinically driven. So ESR is raised, then we need to take a proper history and a proper physical and find out where is the pain or where is the pathology. Suppose a patient has come to you with the raised ESR above 100 without any symptoms. Then the textbook says that you should not go into a very exhaustive search for the pathology. You have to wait for some time to see whether it is progressively increasing or not. If it is progressively increasing, then one next step what you have to do is that if there is a patient with the raised ESR without any symptoms, then you have to go for first examination, you have to go for a chest X-ray to see whether there is any tuberculosis infection in the chest or if there is any malignancy in the lungs has to be ruled out. Then you have to go for a renal function test because most of the renal pathologies cause a very raised ESR. And next you have to go for a LFT. In liver pathologies also, the ESR will be very much raised. Then you have to go for a urine routine also to see whether there is any urinary tract infection or not. Then a blood routine examination, a TC, also has to be checked to find out whether infection is the cause for the raised ESR or not. Then finally an ultrasound of the abdomen. An abdominal ultrasound also has to be performed to see whether there is any tumor pathology or any infective lesion or any occult abscess is present or not. So I repeat, if an asymptomatic patient comes to you with a raised ESR, if you want to go for an investigation, then first investigation is the chest X-ray, then RFT, renal function test, then LFT, then total count, and an ultrasonography of abdomen and urine. These are the primary investigations to be carried out in an asymptomatic patient. If the patient is symptomatic, then we have to diagnose, or we have to follow the investigational path according to the clinical condition of the patient. If there's a bony pain, then definitely you have to suspect, especially multiple myeloma is also another condition, especially if a patient in our Ayurvedic clinical practices, 50 or 60-year-old, 60 or 70-year patient came with the bony pain, and if the ESR is above 80, but always suspect about a multiple myeloma. Then plain X-ray of the skull or hips or a spine need to be checked to find out whether there is any puncture out lesion, which indicates a multiple myeloma or not. So likewise, you need to go step by step to find out what is the reason for the raised ESR. Then C-reactive protein. C-reactive protein is an acute phase reactant. That is called as C-reactive protein, which is an acute phase reaction. That means as soon as an infection happens, and immediately this protein will be released into the bloodstream. So before the symptoms like pain and fever starts, the patient will be having a raised C-reactive protein. That is why if you suspect appendicitis, etc., we depend upon C-reactive protein, because it will be released immediately after the infection. At the same time, so if you want to check about the efficacy of a medicine, if you give some medicine, whether the medicine has responded to the present pathology, we can check C, because within 18 hours the C-reactive protein will fall. So C-reactive protein is very, because it is a direct sign of the, if you see the difference between C-reactive protein and ESR, C-reactive protein is a direct sign of inflammation, and ESR is an indirect sign of inflammation. C-reactive protein responds very fast. At the same time, it goes very fast. ESR gradually only gets increased and goes gradually also. But C-reactive protein is an expensive test, and ESR is an inexpensive test. These are the difference between C-reactive protein and ESR. So any marked raise in C-reactive protein or ESR should be properly investigated. So that's the difference between C-reactive protein and ESR and its clinical utility. Next slide, please. So next is the liver function test. So as you know, liver is the largest organ in our body. It is the largest and the most complex organ of the gastrointestinal tract. The liver is composed of mainly three systems. One is the hepatocyte, concerned with the metabolic reaction, the macromolecule, especially protein synthesis and degradation and metabolism of glucose, lipoprotein, etc. The biliary system involved with the metabolism of bilirubin, and the third system is the reticuloendothelial system, concerned with the immune system and the production of heme and globulin. So the assessment of these three systems, that the hepatocyte, biliary system, and the reticuloendothelial system, can be done with the help of a simple blood test called as liver function test. So liver function test can measure function of each of these three systems conveniently and virtually non-invasively by determining the level of special analytes. So the tests are mainly done, the liver function tests are mainly done to determine the presence of liver disease. From the LFT, we can find out whether the patient is having any liver disease or not. Second is the type of liver disease. What type of liver, whether the patient is having a obstructive type, a tumor type, or an infective type, that also can be assessed with the help of the liver function test. Next is the extent and progression of the liver disease. The extent and progression of the liver disease also can be identified with the help of this liver function test. Mainly 6 types of liver disease can be identified or diagnosed with the help of a simple blood test. One is the hepatitis, cirrhosis, biliary disease, space occupying lesion, and passive congestion and fulminant hepatic failure. So these 6 diseases can be diagnosed just by a simple liver function test laboratory examination. I repeat, hepatitis can be diagnosed with the liver function test. Cirrhosis can be diagnosed. Biliary disease, in a space occupying lesion, that means tumor, in a passive congestion or a fulminant hepatitis, that means liver failure. These 6 conditions can be diagnosed with the help of the liver function test. But one thing you have to always remember, liver function test has got some shortcomings also. That can be normal in a patient with a serious liver disease and abnormal in patients with the disease that do not affect the liver. So this is one of the shortcomings with the liver function test, but that's a rare thing. But liver function test can usually help to diagnose these 6 conditions. Next, suppose next slide please. So whenever you get a patient with an LFT, you consider liver function test as SGOT, your eyes will go only to the SGOT, SGPT and bilirubin. And you say that is the liver function test. But actually SGOT, SGPT and bilirubin, and SGOT and SGPT, they are not the real liver function test. Next slide please. The real liver function tests are bilirubin, protein, that means serum albumin, serum globulin and prothrombin time. These are the real liver functions, because the function of the liver can be assessed by looking into the protein level, the bilirubin level and the prothrombin type. The SGOT, SGPT, they will not assess the function of the liver, but only inflammation of the cells can be shown by the SGOT and SGPT. But our eyes will go to SGOT, SGPT is normal, means we said that the liver is absolutely normal. It is not the case. Always look into the protein, especially albumin and globulin, bilirubin, and if you suspect any major liver disease, prothrombin time also has to be assessed, because they are the true test for liver function. Next slide, please. So when you get a LFT, there will be a total bilirubin. The normal bilirubin is up to 1. If it is above 1, we consider it as a case of bilirubin. So there are 2 factions. One is the direct bilirubin and second is the indirect. That means one is conjugated and second is unconjugated. Unconjugated means it is before the liver. Once it enters the liver, it gets conjugated. So any raised in the unconjugated bilirubin, that means only that is pre-hepatic jaundice. That means only if the indirect bilirubin is increased, that is called as, we consider it as a case of pre-hepatic jaundice. Next. Suppose you get a liver function test. 3 is the total bilirubin and 2.5 is the unconjugated bilirubin. We consider it as a case of hyper unconjugated bilirubinemia. If there is only unconjugated bilirubin is increased, then it is called as pre-hepatic jaundice, and 3 diseases need to be considered. One is the hemolytic jaundice, Gilbert syndrome and Crigler-Najjar syndrome. And the most common, suppose in hemolysis, usually the bilirubin goes above 3, etc. But in case of Gilbert syndrome, normally it goes up to 2.5 or 3. So if you suspect a hemolysis, you can go for a test called the Coombs test. If the Coombs test is normal, then it is not a case of hemolysis. If we rule out a hemolysis, then the most common cause for isolated unconjugated bilirubinemia is Gilbert syndrome. Usually the patient will be having a hyperbilirubinemia up to 2.5 or 3. Maximum it may go up to 5. Whenever there is a fever or other infective conditions, that it may go up to 5. But always unconjugated bilirubinemia. So I will tell you how to manage a Gilbert syndrome. Usually in the clinical practice, many patients come and say that I am having an elevated bilirubin. It's 3 or 4, but only unconjugated. Doctors generally give too much of medicine, take this, and continuously they will be treated, saying that you are having a jaundice. But usually Gilbert syndrome does not require any medicine. But if you tell in my clinical practice, initially when I started my clinical practice, usually whenever I diagnose a case of Gilbert syndrome, I usually tell the patient there's no need of medicine, but patient will not go to home. Instead, they go to some other doctor and find out whether it is normal or so. Now what I do is that whenever I diagnose a patient with the Gilbert syndrome, I give some medicine. It may be the medicine which is more in the shelf, like Kumarias or etc. Any placebo medicine will be given. Usually hepatoprotective, usually if it is there, hepatoprotective. And ask the patient to check the bilirubin. Gilbert syndrome, if they check the blood levels after taking a heavy meals, the bilirubin level goes very low. So if it is 2.5, it may go up to 1 or 1. So we can convince the patient that now the bilirubin level has come down with the medicine. Then you start educating the patient. Now this is a case of Gilbert syndrome. Your bilirubin level has come down. It is only an unconjugated fraction is increased. It happens with the 10 to 20% of the people where there will be a defect in the enzyme where the conjugation takes place. It does not require any medicine, and it can repeat whenever you are having an infection like fever, etc. And educate the patient. But trying to educate immediately after getting a blood report will not work. That's what I learned from my clinical practice. I may be having a limited convincing power. You can try other ways also. This is what I tell from my clinical experience. Next condition is called as Crigler-Najjar syndrome. It's an inborn cause. There are two types of Crigler-Najjar syndrome. In this case also, you can manage. That's about the isolated increase of unconjugated bilirubin. Next slide, please. In Crigler-Najjar syndrome, the type 2 usually get only type 2. The type 1 is very serious form where the bilirubin levels will go above 20, and the patient will be having kernicterus. Kernicterus means there will be a bilirubin affects the brain, and it leads to a mental retardation, because it affects the basal ganglia and the lenticular nucleus and causing severe motor dysfunction and retardation. Now, if the patient is having an isolated increasement, only conjugated bilirubin is increased, then we have to consider two diseases. One is the Dubin-Johnson syndrome and Rotor syndrome. Dubin-Johnson syndrome is an inborn error of metabolism where there will be a blockage of excretion canal. That is called as Dubin-Johnson syndrome. And usually the bilirubin goes only up to 2 to 5 only. There is no need to worry. Then Dubin-Johnson syndrome generally does not require any treatment. In Rotor syndrome, that's an autosomal recessive disorder. This is accompanied by very high bilirubin. We generally don't get this Rotor syndrome. Dubin-Johnson syndrome we may get. So if it is only conjugate is raised and unconjugated is normal, and all the other fraction of liver is normal, and only conjugated bilirubin is raised, then we need to suspect about a Dubin-Johnson syndrome and Rotor syndrome. Next slide. Then SGOT and SGPT. So suppose if you suppose if you have a mild doubt whether the patient is having a hepatitis or not, whether you will check SGOT or SGPT. You have to always check SGPT because SGPT is only related with the liver. The normal SGPT value is 5 to 40. And if the SGPT is normal, means there is no hepatitis or there is no inflammation to the liver. Next. As far as the SGOT or AST is concerned, it is found not only in the liver, it is found in the heart, muscles, intestine, pancreas. So it is not specific to liver. Suppose if the patient is having a MI, the patient will be having a raised SGOT. It does not mean that the patient is having a liver disorder. So if you suspect a liver disorder, it is already a hepatitis, it is better to go for SGPT, not SGOT, because it can be found in many other conditions like of heart involvement, muscle involvement, intestine involvement, pancreas involvement. There will be SGOT will be raised. So normally in hepatitis, the patient will be having we call it a hepatitis when the SGOT or SGPT goes above 300. Up to 300, we consider it as a marginal increase. Generally does not cause much of the, will not be having too much of problem with the liver. In hepatitis, usually it causes above 300 and crosses above 1000. Usually in hepatitis, it crosses above 1000. In alcoholic hepatitis also, it usually goes above 300 and usually it may reach up to 1000, etc. Then what is the value? Usually in hepatitis, where the SGOT will be more raised or SGPT will be raised. Usually in hepatitis, SGPT will be, and viral hepatitis, SGPT will be raised than SGOT, or usually it is equal also. But one exception is there in alcoholic hepatitis. I repeat, in alcoholic hepatitis, usually SGOT will be raised. SGOT will be raised 2 to 3 times than SGOT, because that is only an exception whether the SGOT will be raised above SGPT. So that is how we can diagnose alcoholic hepatitis. Or if the patient says that I don't drink, just by looking into the level of SGOT, which is 2 or 3 times more than SGPT, we can diagnose it as a case of alcoholic hepatitis. Next slide, please. Next is enzymes which reflect cholestasis. One is alkaline phosphatase. Suppose you get a LFT in your hand with the raised bilirubin and raised alkaline phosphatase. It indicates that there is an obstruction to the biliary tract. Either it could be a renal stone, it could be a gallbladder stone, or it could be a tumor, or any obstructive pathology is the reason for the raised alkaline phosphatase. So if you get a patient with a raised alkaline phosphate, immediately send the patient for an ultrasonography study to find whether there is an obstructive pathology. Usually, raised alkaline phosphatase with the raised bilirubin, the ultrasonography shows there will be dilated biliary radicals. Either a gallbladder stone is obstructing, either a periambular carcinoma or any cancer or any tumor could be the pathology. So obstruction will be one of the reasons for alkaline phosphate. I'll tell my one of the clinical experience which I had. My own uncle who had a jaundice and gone to a doctor who hails from did this MD from a Vellore Medical College. And he checked the report, and there was some alkaline phosphate slightly raised bilirubin. He said that you are having SGOT, SGPT. He said you had a hepatitis, and hepatitis is solving now. Don't worry, it will be cured within 2 weeks. After 2 weeks, also the bilirubin was slightly gradually increased. Again, he met that out. He said, no, it's SGOT, SGPT is normal. There's nothing to worry. You are recovering from the infection. Just take rest and have. So that time I came to my team and I saw the report. I found that the alkaline phosphatase level was very high. So I immediately took him for an ultrasonography. Ultrasonography said that there is a dilated biliary radicals. Then I sent to my friend Dr. Varghese, who is a gastroenterosurgeon, and he did an ERCP and found that there is a periambullary carcinoma. That means a cancer was causing an obstruction. This doctor ignored that alkaline phosphatase level, because alkaline phosphatase level raised means it indicates an obstructive jaundice. That doctor, she ignored that. So because of that, we lost almost 1 month of time. So after this, a periambullary carcinoma usually holds a good prognosis. But since it's been diagnosed late, he could be surveyed. A Whipple surgery has been done, but only metastasis happened to a single lymph node. But so that one time has been lost from the we lost him. So always in your clinical practice, whenever you get a patient with the obstructive raised alkaline phosphatase level, should check for an ultrasonography study. Next. So one more thing is this alkaline phosphatase increase not only in liver pathologies but in bone pathology. Suppose if you're having a bony tumor, the alkaline phosphatase will be. It is not found only in the bone, but in placenta and in bone also alkaline phosphatase will be present. I'll tell you one example of one more clinical experience also. A small boy has come to me with a raised alkaline phosphatase and raised bilirubin. As I suspected, again, a obstructive jaundice, sent for a USG. My USG was normal. Again, I sent to some one more place for USG, and that also came normal. Then only I studied that alkaline phosphate is found not only in the liver, it is found in the bone also. So in children and old age people, usually when the bone turnover is more, alkaline phosphatase will be raised. Also, then it has been diagnosed as a case of Gilbert syndrome, because only unconjugated factor was raised. I ignored that thing, because when I saw this alkaline phosphate with the raised bilirubin, I immediately sent him for an ultrasonography study. Then tumor markers, alpha fetoprotein in hepatocellular carcinoma. Usually, when a child is been born, the alpha fetoprotein will be disappeared in the blood. But if the patient is having hepatocellular carcinoma, the alpha fetoprotein will be more than 500 nanograms per milliliter. Usually, in patient with the liver cirrhosis is a pre-cancerous condition. So whether it has been turning into a cancerous condition or not, we can always check the alpha fetoprotein level so that we can come to know that patient will be having a proper, sorry, patient is having a cirrhosis but not an established liver carcinoma. Next slide. So this next is the total protein, which you usually ignore in the liver function. My appeal to the practitioners, whenever you get a LFT test in your hand, always look into the protein level. If the protein level is low, it may be 1 or 2 points low, it indicates that the patient is having a cirrhosis of liver. Especially when the patient is having a reduced albumin and increased globulin, patient will be having a cirrhosis. So it may be only marginal reduction, but always never ignore that. Reduced protein and albumin and increased globulin suggest a liver cirrhosis, which generally ignored and neglected in the clinical practice. So never ignore, always, instead of looking at SGOT, SGPT, always look into the protein and albumin and globulin levels. Next. 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 Next slide, please. Next. Due to lack of time, I'm not going into the viral hepatitis. Next slide. 2-3 slides after. Skip 2-3 slides, please. Skip. Next slide. Next. Next slide, please. Yes, this is the summary of the liver function test. So, in, one slide back, please. So, normally, if the one slide back. So normally in hepatitis, I repeat, normally in hepatitis, if there is a hepatitis, bilirubin will be raised, SGOT and SGPT will be raised. Then albumin, and globulin will be normal. So in hepatitis, always bilirubin will be raised, then SGOT, SGPT will be raised, then alkaline phosphatase will be marginally raised. That is seen in hepatitis. In cirrhosis, SGOT will be normal, SGPT will be normal, lactate dehydrogenase will be normal, alkaline phosphatase will be normal, but protein will be low, albumin will be low, and globulin will be high, and bilirubin. So in cirrhosis, only bilirubin will be high, protein will be low, albumin will be low, and globulin will be high. In biliary obstruction, that means in biliary obstruction due to a stone or tumor, the patient will be having a raised bilirubin level. Alkaline phosphatase will be very high. SGOT, SGPT, all will be normal. In space occupant lesion, that's any cancer of the liver, the SGOT, SGPT will be normal. Lactose dehydrogenase and alkaline phosphatase will be higher, and bilirubin will be higher. So always keep this chart in your mind. Please go through this chart once again. It's been clearly given in the Harrison. If you well versed in this chart, you can confidently treat a patient with the liver disorders. Unfortunately, though, Ayurvedic medicine has got a very good role in the management of liver function and liver disorders, but because of fear, many people are not coming. And also, we are not properly equipped to diagnose an LFT. To diagnose an LFT, a simple liver function test is enough with the proper clinical examination. Next. Next is about the thyroid function test. So whenever you suspect a thyroid pathology, first you need to send only for TSH, thyroid stimulate hormone. So thyroid stimulate hormone has to be sent in an empty stomach. That means early morning sample need to be sent, because subclinical hypothyroidism will be missed if you send after a meals. So normally, if the TSH is increased, with the reduced T4, it is a diagnosis of hypothyroidism. I repeat, if the TSH is higher, and T4 is low, it is a case of hypothyroidism. If TSH is lower and if T4 is higher, it is a case of hyperthyroidism. If TSH is higher and T4 is normal, it is a case of subclinical hypothyroidism. I repeat, if TSH is increased but normal T4, it is a case of subclinical hypothyroidism. So the T3 antibody is required when in case of severe hyperthyroidism. Normally, in a baseline study in the clinic, don't send for thyroid function, just send for TSH. Now, if the TSH is increased or decreased, then only you go for T4 or T3. No need to simply waste the money of the patient. So I'm not going detail into thyroid function since we lack time. I'm just skipping that. So basically, keep in this mind, if TSH is increased, low T4, then hypothyroidism. Low TSH and increased T4, hyperthyroidism. Increased TSH and normal T4, subclinical hypothyroidism. Next slide. This is a rheumatoid factor. So normally, suppose if a patient has come to your clinic, he does not have any of the joint pain, etc. And as a routine test, you did an RA factor test and you find that RA factor is positive. Do you consider him as a rheumatoid arthritis patient? No, should not consider him as a case of rheumatoid arthritis, because a patient above 65, 20% of the patient above 65 years can have a RA factor positive. That does not mean that he is a case of rheumatoid arthritis. Or if you had undergone a vaccination or a blood transfusion, you can have a temporarily RA factor positive. That does not mean that you are a case of rheumatoid arthritis. And certain autoimmune diseases like collagen vascular disease, systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, etc., you may be having a RA factor positive. That does not mean that you are in a case of rheumatoid arthritis. And in some other infections like TB, leprosy, malaria, filariasis, and certain liver diseases like primary bilious, in these conditions also you will be having a RA factor positive. So only by seeing into RA factor positive without any joint involvement or without any other supportive sign, don't consider it as a case of rheumatoid arthritis, because you can have a RA factor positive in a normal individual, especially in old age patients. Second case, suppose if a patient has come to you with the joint pain, multiple joint pain, symmetric arthritis, and RA factor is negative. Do you consider him as a case of other disease, or still you consider as a case of rheumatoid arthritis? You have to consider it as a case of rheumatoid arthritis if symptoms match with the diagnosis, because there is a condition called a seronegative rheumatoid arthritis, especially in patient with the wrist pain and etc. Patient will be having a seronegative rheumatoid arthritis. So rheumatoid arthritis, RA factor positive does not diagnose rheumatoid arthritis, or negative RA factor does not rule out rheumatoid. Then what for this rheumatoid RA factor? RA factors generally, it helps in the diagnosis definitely, but it is mainly checked to find out the prognosis of the patient. If at the time of diagnosis, if the RA factor titer is very high, when RA factor titer is very high, then it indicates that patient is going to have a very bad rheumatoid arthritis with the severe erosion and other joint deformities. So mainly to assess the prognosis and to assist in the clinical diagnosis, RA factor is used. Next. This is serum uric acid. In the present day clinical practice is very important, because many ways, suppose if a patient comes with the generalized pain and tenderness all along the spine, you always should consider about a uric acid. So normally, if the patient complains with pain in one or two joints, always you should consider, because in the present clinical practice, patient with the gouty reaction is very common. So severe tenderness on the whole along the spine and endosopathy. Suppose at the insertion of the tendons, at the site of bony insertion, if the patient has got a tender points, always doubt about a gouty reaction. So you can send for a uric acid level. So suppose if a patient come with severe pain, tenderness and redness in the metacarpophalangeal joint, you send for a uric acid. The uric acid level will be normal. Will you rule out the gouty reaction? No, you should not, because whenever in acute stages, what will happen? The whole of the uric acid will crystallize at the site of inflammation, and you may get a normal or a subnormal uric acid level. So never, because uric acid diagnosis has to be always clinical diagnosis. But to see, just to find out, well, especially tell the patient it is a case of gout, but I am sending the blood sample. But if the blood sample is low, also I will not rule out the gout because of the educate the patient. Otherwise, patient say the doctor said I am having a gout, but my uric acid levels are normal. And patient can have a gouty reaction with a normal uric acid levels also, because sometimes patient may having a level of 3, but still can have a gouty reaction. So the diagnosis is purely clinical diagnosis. Next is autoimmune disease. Autoimmune disease, you have to send for an ANA test. Suppose if you suspect a butterfly rash, multiple joint pain, if you are having a thickening of the skin, there are many conditions like systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, polymyositis, dermatomyositis, etc. You need to send for ANA. ANA will be positive in all autoimmune disease. But there is a test called ANA profile. ANA profile means there is a fraction of all which autoimmune disease is the cause you will get in the ANA profile. It's a slightly expensive test, like 3,000 or something. So there are many tests, like if you go for an anti-dsDNA test in the ANA profile, anti-dsDNA positive means it is indicative of an SLA. Anti-Smith antibody test positive means it indicates again with the lupus, systemic lupus erythematosus. If anti-RNP or ribonucleoprotein positive results are seen in mixed connective tissue disorder. Anti-SSA, that means anti-Sjogren's syndrome, that is positive in Sjogren's syndrome. Anti-SSB, again in B type of anti-Sjogren's syndrome. Anti-SCL70 scleroderma antibodies, that is positive in scleroderma. So just for your information, if you get an ANA test done, if it is positive, you still doubt about what type of autoimmune disease, you can send for an ANA profile. ANA profile helps you to diagnose what type of autoimmune disease. Next. Blood sugar, okay, I am not going into the, you all know about the blood sugar. Next. This is the renal function test. So renal function test, in case of acute, if you suspect an acute renal pathology, always depend upon blood urea. The normal level is 15 to 45. If you suspect a chronic renal pathology, always send for a serum creatinine. The serum creatinine normal is 0.8 to 104 in male and up to 1.3 or 1.2 in female. But sometimes you will consider, oh, I am having only 1.6 or 7. But always think that if the creatinine level will be raised above 1 point or 2 point, by that time 50 to 70% of the kidney will be damaged. So don't ignore if it is only marginal rise in creatinine level. Also always be cautious, because almost 50 to 70% of the kidney would have been damaged by the time there is a raised creatinine levels. Next. ASO. So why I include ASO is that now ASO test is one test which we generally we usually overdo it or overdiagnose rheumatic fever. So ASO titer means whenever you are having a streptococcus infection, suppose if you are having a streptococcus throat infection or streptococcus kidney or glomerulonephroid, you will be having a ASO titer. ASO titer increase does not mean that you are having a rheumatic fever. If the signs and symptoms of rheumatic fever like carditis, renal pathology, joint pain, then snake-like rash on the skin, especially in children below 15, then only you should send for an ASO titer. In adults, simply sending ASO titer is not the proper practice, and never overdo the ASO titer. Because if you are having a streptococcus infection, throat infection, you may be having a ASO titer. That does not mean that you are a case of a rheumatic fever. So nowadays, most of the modern doctors does not do too much of ASO, especially they do more in the children above 15 years old. Nowadays, the prevalence of rheumatic fever has reduced because of the proper use of antibiotics. Next. Prostate specific. Many a times we can diagnose prostatic cancer just by a PSA test. Suppose if a patient presents with the signs and symptoms of benign prostatic hyperlipidemia, frequency of micturition, urgency, hesitancy, etc., send for an ultrasonography. If ultrasonography says that there is a if the volume of the prostate is increased, send for a PSA test. Normally, up to 4 is the normal level of PSA. If it is above 10, there is a chance, 25% chance that patient may be having a prostatic cancer. Send for a biopsy of the prostate. If it is above 10, there is always a 50% chance that they may be having a prostatic cancer. So PSA is very important because I could save many patients with the prostatic cancer because of the early detection with just the PSA test of 100 rupees. So always PSA test is very, because we do we cater more to geriatric patients. So always look into the prostatic specific antigen. Next. This is fine. Last slide. That's about the urine analysis. The slide is not 10. Please change the slide. Okay. So normally in the early morning sample you'll be having 50 to 300 ml. If it is more than 500, it indicates that the patient is having a severe diabetes or polyuria. If it is less than 20 ml, it indicates an anuria, indicates a renal failure. Normally the color is pale yellow. If it is dark yellow, it indicates a liver disorder. If it is white, it shows the presence of pus. If it is pink or red, it indicates the presence of red blood. Pink or red can indicates not only blood. If you had a beetroot, if you have got a color food items, you may have a red blood. So should not always suspect as a case of blood. Then brownish black indicates a alkaptonuria, or there is a presence of homogenesic acid. Next slide. Next, appearance. Usually it is clear, sometimes cloudy. Turbidity which shows that there is a WBC. Next slide. So order in sediment formation, usually sediments are not seen. If there is a pus cell, RBC cyst or epithelial cells, it indicates there is a infection. That's a specific gravity. Usually the specific gravity is 1.003 to 1.060. Low specific gravity indicates a diabetic insipidus or a chronic kidney infection. High specific gravity indicates a diabetes mellitus or a glomerulonephritis. Next. Next, protein. Usually protein is absent in the urine, but if there is a protein is present, it can indicate a serious disorder to mild disorder. If there is a proteinuria, it can be because of a condition called a proteinuria. It can occur even in dehydration, heart disease, and severe any of the dehydrating condition. You can have a protein in the urine. If protein is seen in the urine, you have to always examine, because especially if microalbuminuria is seen, it indicates an impending renal failure, especially in patients with the diabetes mellitus. If you see a microalbuminuria, it is a sign that patient is going into a case of diabetic nephropathy or impending renal failure is expected. So always if you see a protein in the urine, always it can be a milder disease or due to increased intake of simple intake of red meat could be one reason. Otherwise it can indicate even severe conditions like multiple myeloma, etc. Then okay, slide has changed. Excuse me, I can't see the slide. Okay, I will finish it. A few more things. Suppose in pus cells, if it is more than 6, then you can suspect a urinary tract infection. If it is above 10, then only we require an antibiotic. If bacteria is seen along with the pus cells more than 10, then it indicates a urinary tract infection. You should send the sample for a culture and sensitivity, and based on the sensitivity, appropriate antibiotics has to be used. If there is a hematuria, if presence of blood is seen in the urine, then you have to send the patient for an ultrasonograph study to find whether there's a stone or bleeding renal cyst, etc. So this is about the urine routine examination. So here ends the topic of laboratory investigations. I am not able to see the slide, so I can complete it. So if you have got any doubts, you may ask. And this topic has to be taken in a matter of 4 hours. That to a direct interaction will only definitely can put this idea into your head through online. I don't know how far I am able to convey the interpretation of laboratory investigation. I'm not sure, but at least it will help you to help for a to just a platform to study further yourself. Thank you, one and all.
If anybody having doubt, you can please ask.
Or if you can put the last slide, actually my WhatsApp number is there. You can even send into my WhatsApp. Any doubts you can ask through my WhatsApp also. Or you can mail to me regarding the opinion of the class or any doubts, you can mail me. I can reply you back. So if there is no doubts, means actually the class has gone 1.5 inches above the head. That would be the reason. Yeah.
Sir, nalla class ആയിരുന്നു. അത് കാരണം തന്നെയായിരിക്കും doubts ഒന്നും ഇല്ലാത്തത്. അല്ല, കമന്റ് ബോക്സിൽ നല്ല പ്രസന്റേഷൻ എന്ന് പറയുന്നുണ്ട്.
Okay.
സ്ലൈഡ് ഷെയർ ചെയ്യാനൊരു ഇപ്പൊ ചെയ്യാട്ടോ. സാർ ഡൗട്ട്സ് ഇല്ലാന്ന് തോന്നുന്നു, നമുക്ക് കൺക്ലൂഡ് ചെയ്യാം. സാർ വളരെ ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള ക്ലാസ് ആയിരുന്നു കേട്ടോ. നമുക്കത്
ടൈം ഇത്ര പോരാം എന്താണ് ഇത്, പിന്നെ രാത്രിയായി എല്ലാവരും ചോർമാനും ഒക്കെ ഉള്ള തിരക്കിലാണെന്നുണ്ട്. എനിക്കൊരു ഡയറക്റ്റ് 4 hours വേണം നമുക്ക്. പിന്നെ സ്ലോലി അത് എടുക്കണം, എങ്കിലാണ് അത് യൂസ് ഉണ്ടാവുള്ളത്. ജസ്റ്റ് ഒരു ബേസിക് ആയിട്ട് ഇരിക്കട്ടെ.
സാർ അപ്പൊ നമുക്കൊന്ന് കൺക്ലൂഡ് ചെയ്യട്ടെ സാർ. എന്നാ നമ്മുടെ വർക്കല ജില്ലാ ഹോസ്പിറ്റലിന്റെ പേരിലും ആറ്റിങ്ങൽ ഏരിയ കമ്മിറ്റിയുടെ പേരിലും സാറിന് നന്ദി അറിയിക്കുകയാണ് സാർ. അപ്പൊ ഇത് നമുക്ക് കുറച്ചുകൂടി ഒന്ന് വാസ്റ്റ് ആയിട്ട് ഒരു തവണ ഒരു പകലെപ്പോഴെങ്കിലും സാറിന് സൗകര്യമുള്ള ഒരു സമയത്തെ നമുക്കൊന്ന് എന്നാലും നല്ല ഭയങ്കര യൂസ്ഫുൾ ആയിരുന്നു സാർ ക്ലാസ് കേട്ടോ. നമുക്കത് ഒത്തിരി ഫോളോ ചെയ്യാൻ പറ്റിയിട്ടുണ്ട്. ഒരുപാട് നന്ദി. ഒരുപാട് സാർ. ശരി സാർ, താങ്ക് യു. സാർ നമ്പർ നമ്മള് ഒരു അവർക്ക് മെയിൽ ഐ ഡി കിട്ടിയിട്ടുണ്ട് എല്ലാവരുടെയും. അപ്പൊ സാറിന്റെ ആ ലാസ്റ്റ് സാറിന്റെ നമ്പറും മെയിൽ ഐ ഡിയും ഒന്ന് അവർക്ക് ഞാൻ ഫോർവേഡ് ചെയ്തേക്കാം. ഡൗട്ട്സ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ശരി.
Okay, so shall I leave?
Yes sir.
Thank you.
Okay sir.